Welcome to the webinar Implant Overdenture Overview. The lecture will be presented by Wendy A. Clark, DDS, MS, and we will begin shortly. And with that, it is my distinct honor to introduce Dr. Wendy A. Clark. She completed her undergraduate training at the University of Georgia and earned her doctoral degree from Marquette University School of Dentistry. She then earned her master's degree in clinical dentistry and her certificate in postgraduate prosthodontics from the University of Alabama at Birmingham School of Dentistry. Dr. Clark practiced prosthodontics for 7 years with Team Atlanta and lectured nationally on a variety of topics, ranging from smoking cessation to dental implants. She was named a leader in continuing education by Dentistry Today in 2017. Currently, Dr. Clark is full-time faculty at UNC Chapel Hill Department of Prosthodontics. And it is now my honor to say, take it away, Dr. Clark.
Thank you so much, as always, Jessica. I am a consultant for several digital denture companies, and none of those companies are sponsoring me today. So any pictures of anything is just for education only. So I learned recently that not a lot of people really love complete dentures when they're in dental school. And this is from a very important source, which is Reddit, subreddit for dental school. And there was really fantastic responses across the board about my personal hell would be an endless line of occlusion rims. I hate dentures. They made me cry. So a lot of dentists don't offer this service in their private practice. They hated it in dental school. They go into private practice and never really feel comfortable or enjoy seeing that patient population. However, there is truly a need right now. There is a wide range of edentulous people affecting nearly 300 million people globally. So this is truly an epidemic. The most recent edition of from the World Health Organization of Healthy People 2040 actually showed an increase in the percentage of edentulism in the most developed countries. And so it's really fascinating. And there is a rate where higher income countries were actually showing increased rates of edentulism. So this is a big deal, and it's a disease burden that I would like to hope that I can train my dental students to not be so hesitant to care for those patients. We've been looking at this population since early 2000s. At that time, they found that the number of edentulous patients was decreasing, which is now changing. But the absolute number of edentulous patients was rising and expected to continue to rise over several decades as the population aged. So when we have our completely edentulous patient, we were really presented with these main options, which would be conventional complete dentures, implant-supported overdentures, and implant-supported fixed prosthetics. I've previously done webinars on complete dentures and implant-supported fixed, and today we'll be rounding out the bunch with removable implant overdentures. So to touch base, digital dentures are a nice way to kind of incorporate complete dentures into your practice. They offer a lot of different methods that haven't been available before, can decrease treatment time and treatment cost. The materials have been improved, showing greater preservation of records throughout the treatment, fewer lab steps, better material properties, and so on and so forth. However, they are still complete dentures. And so when you blow out your birthday candles, they can still fall out. So we can improve that by adding some implant assistance. However, some patients are not candidates for implant overdentures, and that would be for medical reasons. There's very few medical contraindications that will prevent implant placement or any dental surgery, particularly radiation to the head and neck, and very uncontrolled diabetes, heart conditions. You can only have dental implants after you've finished your growth in most areas of the mouth. We'll talk a little bit about that. So usually we talk about the cutoff age for dental implants being in the 20s, usually around 21, 18 to 21 for females, around 25 for males. Finances are often a reason that prevent people from getting dental implants, as we hear a lot in our practices. And lastly, personal preference. Some people just don't want surgery, and that's okay. So we talked last session about full arch fixed implant solutions like All-on-4. Though that choice is often patient driven. There's a lot of marketing. Clear Choice is a really big company that was based out of Atlanta, and they were actually advertising through the AARP magazine there. So patients were coming into our practice with AARP leaflets talking about All on Four. So there's lots and lots of marketing out there. But usually what I'll hear is patients don't want to take their teeth out at night. There's a totally different psychology for having an implant supported fixed versus anything removable, even if it's implant supported. You still have to have your teeth in a glass. So we do still do implant overdentures, however. What indications would we choose removable implant supported options over a fixed implant supported option? Hygiene is my #1 indication where we're looking at whether or not we're going to do something removable or fixed. I have seen implants very, very, very successful in my caries patients. When I do see peri-implant mucositis and implant issues, it's notoriously in the patients that have that history of periodontal disease. And so if a patient had that bacteria in their mouth, they're going to be more prone to issues, and being able to take the prosthesis out to clean it both professionally and at home makes a big difference. So there have been shown to have improved soft tissue outcomes, improved hygiene and tissue health with removable versus fixed. It's easier to clean for us and for them. And the last but not least, I think this one's overlooked a lot, is going to be soft tissue support. So kind of the lip support, cheek support, and kind of that mid-facial area. And as we age, we lose collagen for one thing, but as we lose our teeth, we also lose bone. And so it's very common to see that lack of support in the mid-face area. And you start to see the deepening of the lines here, the nasolabial folds, and just kind of losing that youthful appearance as we lose our teeth. So implant overdentures can be a solution for that. As when our teeth are out, the bone goes away. You may remember this from dental school as Wolff's Law. When there's no teeth, the bone doesn't have a job to do. It's constantly remodeling, and if there's no teeth, it doesn't remodel in a way that maintains that structure. When we have dental implants placed, that can help instigate that bone remodeling to help maintain the bone position. Interestingly, removable prosthetics actually lead it to more bone loss. They accelerate bone loss. And this is a conversation I've had to have with a lot of my patients where implants load the bone because they're down here in this basal bone. When we put a denture on or a partial denture, it's really just loading the crestal bone, which actually cuts off the blood flow to the deeper bone. So as patients wear their prosthetics more, they're more likely to have bone loss. And it's progressive, it's irreversible. When the teeth are gone, the bone loss continues. We see the greatest amount at first year after extraction, but it does continue at a very small rate for the rest of the patient's life. And we know that the prosthetics accelerate bone loss, but this study interestingly found that a lot of patients, the majority of patients, wear their prosthetics at night too, and a lot of patients actually sleep in their complete dentures and partials. So wearing that at night, flinching on it, that's going to cause that bone loss to further progress. When we lose bone, we have a maxilla on the left and an upside down mandible on the right. The maxillary bone resorbs towards posteriorly, like towards the throat, and it goes up. So it's kind of up and back. The mandible resorbs at a different way. So it still gets shorter, but it resorbs outwards. And so one of them's resorbing back this way, the mandible is resorbing out this way, which results in that pseudo class 3 appearance, where it looks like patients have gotten a bigger mandible as they've gone through their lives. With that, we start to see that lack of support in the mid-facial area. A lot of times we'll accommodate this with our complete dentures by flaring the teeth out more and more and more, so we don't have to arrange our patients with an underbite or that class 3 appearance. And as we continue to do that, the teeth come out further, they're continuously flared, the flange gets thicker and thicker and thicker, and the flange replaces the missing soft tissue structure, and we're still trying to accommodate to keep those teeth out further. And this is something we can do with removable, and this is something we absolutely cannot do with fixed implant prosthetics. And I think this is one of the number one problems I see when I have patients come in with failing all on fours, is because somebody, the lab or provider or the patient, demanded to have that lip support from their fixed prosthesis, and it creates this ledge that is so uncleansable that you just have this microcosm of bacteria just swimming around. So if your patient needs that lip support to be pulled out to accommodate for missing soft tissue, it really needs to be a removable prosthesis. That's one of the other challenging things about going from a complete denture to a all-on-four or a fixed prosthesis, because the patients are used to seeing themselves with a flange, with that denture base extending up into their vestibule. And as soon as we make something fixed, that's totally gone. And it just changes their entire look and their entire appearance. There is a way to test that where you can make a denture and actually cut off the flange here so that a patient can see what it would look like without that lip support. It's a lot easier now with digital than it used to be with conventional. So you can actually make like a monolithic try-in that doesn't have a flange, so the patient can test that lack of lip support to see if functionally and aesthetically they can tolerate that. The mandible, we see a lot more aggressive resorption than on the maxilla, and we're fighting the tongue. So on the maxillary, we always win because we have the palate, and that helps us with that suction cup effect as we get the 360 degrees around. On the mandible, we don't have that, and we have a tongue in the way that's trying to kick the denture out of place. And when patients have been edentulous for a long time, it's super common to see where the floor of the mouth actually comes up and covers, the mylohyoid actually comes up and covers the crest of the ridge during function. We see the geniotubercles completely exposed, which can be an area of sore spots. A lot of times that mentalis muscle will be attached right at the crest of the ridge. And so basically all these muscles are kind of collapsing in and covering up the plates that's supposed to support your denture base. And this is, again, not as big of a concern on the maxilla. We have the hard palate that doesn't go away. And because of this, we have found that actually the majority of mandibular dentures are very challenging to wear. This was a really cool study where mandibular dentures, brand new at the time of insertion, mandibular dentures were evaluated by a clinician, a patient, and a technician. And at the time of insertion, these were found to lack either support, stability, or retention, or a combination of all three. And the other thing that study found was that patients had higher expectations for what these dentures would look and feel like than the clinicians and technicians did. So we're delivering something that is what we know is acceptable and the best we can do considering their anatomy, but it hasn't been communicated to the patient that, oh, shoot, this is what it's going to feel like. So it's important to kind of set those patient expectations as you're walking through the process. And there's only so much you can do with a soft tissue supported complete denture when patients have had that much resorption. Patients are living longer, more independently, and they really just have high expectations for how they can function. And because of this, we find that the mandibular arch is usually the place we go first when we're considering implant overdentures. So if a patient has a set of complete dentures, usually they'll get a huge gain in function and patient satisfaction on the mandibular, and they're not going to see that same amount in the maxillary. And this was quantified in a study from 2005 that found that there's actually a 36% increase on the mandibular arch when the two dental implants were placed. And beyond that, there is a group that came out, the McGill consensus, that concluded that because mandibular implants are so successful and so predictable in this lower anterior area, that we should actually be considering that as our first line of treatment planning when a patient comes in that's completely edentulous, that we should be treatment planning that first before we recommend a mandibular complete denture. So I take that to mean that a mandibular complete denture is slightly below what we should be offering as our initial standard of care. And again, it's not going to be the treatment for everybody. Some people will get mandibular complete dentures, and it's important to know how to make those too. So again, just reiterating from another consensus statement saying that, yes, there's so much evidence that we should be offering this as a first choice. It's very successful, relatively easy to do compared to some of our other treatments. And with the vast increase in patient function and satisfaction, it's a really excellent choice. So there's a couple different types of overdentures we're going to talk about. The first is going to be the single attachment denture. Today in 2024, these are primarily locator overdentures in the United States. There are a few other types of attachments, and you'll see one in this image here is a ball attachment or a ball abutment. So anything that is not splinted, it's like a stud type attachment that receives a male and female component, that would be considered a single attachment denture versus a bar overdenture. Some other historical ones that you can see here on the left is an ERA attachment. These were very popular when I was in dental school. And these only had an internal retention. So they look very similar to locators, but they don't have something that snaps on the outside. They just had a plug that went on the inside. And on the right, you'll see the ball abutment. These you still see with some implant companies, especially the mini implants, and they only have external retention. So they don't have an internal component. They just have a little donut that snaps around that ball for retention. Locators have both internal and external retention. And so you can see on the left, if you look here straight down, there's a hole in the middle of each one. The plug on the attachment snaps in there. And if you look on the right, there's this little ring around there. The lip of the attachment will actually grab on the outside. So you're getting two kinds of retention, which is really great because if you lose one, if you get the locator attachment plugged up on the top with tartar and plat, it can usually still snap around the outside. Having that external retention also allows for a greater degree of divergence. So you'll see as we go along, there's some locator attachments that don't have the plug on the inside. They only have the outside. And those are kind of the, we used to call them the divergent ones. They're like a lower retention and they can accommodate up to 45 degrees of divergence. This is showing all the different components. So you have your implant placed at the bottom. The gold part you see here is your locator abutment that gets torqued in. You code these as a prefabricated abutment using that CDT code. They come in a package, you torque it in based on the implant company, that will be your Newton centimeters. And then inside the denture, you pick up this little silver cap, and that's the locator housing. And then the attachments are inside of that housing. So to kind of walk through, we have our healing abutment. We remove the healing abutment and place our locator, and the locator is on the right, this gold one. This is a newer type of locator that's coated with a zirconia nitride coating that's supposed to help with some of that biofilm formation. So for my patients that have higher plaque, this works really great. And the majority of patients we see now, however, are 2 implant overdentures on top of locators. And so you see here 2 locators on a mandibular arch. This is our standard. We do a ton of these in the dental student clinic at University of North Carolina. And so this is kind of our baseline for how we train our dental students. And one of the most important things I hope to get across to them, as well as anybody that wants to learn more, is that these are implant retained overdentures. You still get your support and your stability from the soft tissue. This is always a question on my midterm. That an overdenture with 2 implants is implant retained, but soft tissue supported. So you're still getting support and stability from that flange, which means your denture actually has to fit. So that means we have to go through the whole sequence, border molding, custom tray, all of that to gain the ideal denture base that fits well against the tissue. Because we're gaining that support and stability from the denture base itself against the soft tissue. And unfortunately, we can't just take a poorly fitting denture that the patient's had for 50 years, that's lost its retention, and place 2 dental implants and call it a day. We do have to make sure that the patient's dentures fit that they come in with. So usually a reline will be done first, and then the dental implants will be restored. If a patient comes in with a well-fitting denture, it can be used to facilitate implant placement. If they come in with a poorly fitting denture, you want to make that into a well-fitting denture, either by a laboratory reline or with a remake. And it's so easy with digital dentures to remake those following a reference denture protocol. Conventionally, we would create a duplicate of the patient's existing denture. So this is how we taught our students up to very recently, where you make a putty duplicate of the patient's existing denture, and then you can pour a clear acrylic resin in there, and now you have a duplicate of your patient's denture that you can work with for your CT and your surgical guides. This is an example of how you might use that as a surgical guide. You create a window of where you want that implant to be placed, and now you have an indication of the locator being placed palatally to the denture teeth or lingually to the denture teeth. And that's important because it gives you room for your housing without worrying about teeth debonding. We can now do this digitally, which is much, much easier. So rather than making that putty duplicate, we can just scan the patient's existing denture and then print a clear copy of it. Similarly, if you have a digital design of a digital denture, you can just print a spare copy and utilize that as a surgical guide. So this is the same workflow. This is a 3D printed duplicate from a patient's design. And we just open up a window and utilize that as a surgical guide. So it fits a lot better. It's more predictable than the cold cure chairside acrylic resin. So sometimes patients come in with dental implants and they come in with a poorly fitting denture or they don't have a denture at all. And so in that case, we're going to go through all the border molding steps where we capture where the implants already are. And the newest softwares, so the digital design softwares have kind of a stock cutout of the size of a locator housing. And so it'll estimate that for you. So you don't have to do quite as much grinding as we did with conventional implant overdentures. And so when you get your denture back from your lab, it'll look something like this with these windows already pre-opened for you. Oftentimes you need to go a little bit more depending on the path of insertion and the divergence of the locator housings, but it's usually pretty close. And then you'll pick up your locator housings and we'll walk through that next. So these are picking them up chairside. You'll see that we call those processing inserts, or the black ones that come with the housing. So how do we do this? There's two ways to attach locator housings inside of a denture. One of them is the indirect method, and we'll walk through that one first. That's when you have your laboratory attach the housings for you. And the other is direct, and that one's a lot more common now. As it's only a single appointment, it's a lot faster. And there's actually been some studies that show it's more accurate to do this chairside rather than outsource it to a dental lab. So for the direct chairside pickup, your patient comes in with their locators and they have a denture that they want to attach. You'll open up your little vial that has the locator housing, which is the silver thing you see on the left. That's what gets attached inside the denture. It'll come with these little white blockout rings. Those help prevent the resin from flowing around the dental implants. And then we have retentive inserts in different colors. So we're going to take the locator housings and those just snap right onto the locators. So these are like Legos. You pop it on and it snaps right in, and you'll hear a snap when you do it. And then we're going to relieve around that, make sure everything fits. We also want to put these blockout rings. And so here, the white blockout rings are the ones that come with a kit. In this case, we actually added additional blockout resin below because the patient had some bone loss and this was reattaching another denture, and we didn't want to lock in on exposed threads. So at least use the white rings that come with a kit. Sometimes you'll need wax or blockout resin or something else if the patient's had bone loss, and especially if there's threads exposed. And so this is what it looks like with the ring in place, just around the locator, and then this is the ring with the housing snapped on top of it. And these are with the two rings and the two housings. We want to make sure that the denture fits passively over those housings because, again, this is soft tissue supported. So we want to make sure that this flange of the back is actually resting on the soft tissue. So usually I'll use PIP paste. Some people use a bite registration material to kind of mark where the interferences are. It's a little bit faster. But basically, we're just opening up and making sure that there's space for that denture to fit over those locator housings without interference. And so this is showing with a PIP in place to make sure that we are actually touching the soft tissue and engaging back there. Once we're sure that the denture is very well fitting, we can use any sort of chairside resin and pick up the housings. So at this point, the little locator caps, the housings, are still snapped into the patient's mouth. And we have a clean denture that we're going to attach with resin. There's several brands now of a self-curing resin that comes in an auto mix tube, like you see here. It extrudes just like your cement extrudes. There's one from Zeth Thinkers called Chairside. There's one called Voco that's really nice. There's one from GC that's like a Muco hard. They're all very, very good and very easy to use. You'll see some pictures down the line where I actually show mixing like jet acrylic. So really any acrylic resin can be used to attach housings. So whichever one you use, load up the wells that you've created inside the denture, and then seat it back into the patient's mouth and have them close together. The different materials will set differently. Some of them are dual cure. They all have a self-cure component, usually set within 3 to 7 minutes. And then you'll snap the denture out of the patient's mouth. And you should see something like this, where all the housings are intact with the black pickups, and you pop those out. There's a really cool locator tool that I'll show in just another few slides, and this allows you to take the attachments out with an end that has a little grippy on it. So what you're seeing on the last slide was this 8397, the removable part, and that pulls out the attachments and changes them. That piece unscrews and exposes this little plugging looking part, and you use that to snap the locator inserts in, the new fresh one. The gold part here allows you to torque the implant into place. And I don't know what the retention part is. I've never had that remaining on my locator tool. That's always gotten lost. It's like a little clear plastic thing that goes at the end, and I've only seen it in pictures. I think the assistants immediately throw it away when they open up the tool. And this is just showing that again. So this is the removal attachment. You snap that into the black insert and pull that out, or the processing attachment. And then you take that off and expose this inner lining, and that picks up whatever insert color you want. So there's different levels of retention. The blue is going to be the lightest retention, and then there's the white and the pink. You just snap that into place. Alternatively, if you want something that's a little bit less chair time, again, there's pros and cons to each one. You can have the laboratory do this for you. At your final impression step, whether you're doing a reline impression or a final impression, they create these little locator impression caps that snap onto the locators the same way the housings do. And then when you take your final impression, those housings come out, the impression copings come out inside of the impression. So you'll see that there's a black insert here and a black insert here. Those fit with an analog like all the other implant parts. So the lab actually snaps those in and creates a master cast that has the locators positioned on the cast the same way they are in the patient's mouth. So now with this master cast, they can actually embed the housings when they process or reline your denture. So you get the denture back from the lab with those housings already set. So the next thing to consider is going to be the space requirements. So for a complete denture, you need about 6 millimeters of space, of restorative space from the soft tissue to the opposing dentition. As soon as we start to add the attachment and the housing, we have to add another 1.5 millimeters or so for that. And we want the denture teeth and basic filling to be a little thicker to prevent fracture. So ideally, we want at least 8.5 millimeters for our locator overdenture. We can cheat in a few spots and get down to 7.5, but much beyond that, with a conventionally processed denture, you're going to look at teeth debonding and fracture across the locator housing. And these are some of the things you see. Charlie Goodacre published a paper in 2003, so a long time ago, about the different complications we see. And certainly more than complete dentures, we see a higher complication rate with implant overdentures. And the reason being because we take this well-made denture and then we drill a hole in it. And that hole, we're creating a space where the acrylic is thinner. It's going to be more prone to fracture. And so these are really the two most common complications I see. These are two of my cases that failed. And so you can see on the left, we see this very, very often on mandibular overdentures when there's not enough space, where it just fractures right through that housing. And then on the right, you see the teeth debonding. Again, we have to adjust the teeth so much to fit over our frameworks, our locators, and it just weakens the teeth, it weakens that bond. Fortunately, we have our digital denture material that we talked about in the digital denture presentation, where we can now make monolithic dentures with either printing or milling. What that means is the denture teeth and base come from the same puck of material. So there are no separate denture teeth to debond. And this is fantastic because we see this problem a lot with conventional complete dentures with teeth debonding, and then we see that higher rate with implant overdentures. So my go-to choice material right now is monolithic milled or monolithic printed to try to get that strength in the denture base. What you're seeing here is an Abimax denture that has a titanium meshwork built in. So this is actually monolithic milled and milled base and teeth in one piece with a framework embedded already in it. So it's like this very pre-planned case where we don't have to have separate acrylic and separate denture teeth. And this is showing different views of that. So you can see on the left where the milled titanium framework was embedded in that puck of resin. The teeth are part of the same puck. So this is all pink and white, one piece with a framework inside. This is one of my cases on the right, where you can see that we have the meshwork there, the titanium meshwork to support the housings. And then my artistic rendition of holding my denture in the sun to get the light shining through and show that really, really cool titanium mesh framework that was made. So I have not had a patient break one of these yet, knock on wood. It's solid titanium in the middle, and it's really exciting, the things that we can do today that we couldn't do just 5 years ago. Even if you don't add a titanium mesh framework, just utilizing a monolithic milled denture with the base and the teeth in the same puck is going to drastically improve your strength. Additionally, even if you want to have separate denture teeth, so let's say you like the aesthetics of a carded denture tooth, just using a milled base is going to give you that superior strength. So the dentures we make today are much stronger than the dentures we made when I was in dental school. And so hopefully we'll start to see those complication rates go down. This is from one of the labs that I've worked with. This is from their social media page. My friend calls this a redneck scientific study, which always makes me laugh, where we run over 3 types of dentures with a monster truck, and the digital dentures don't break. So if your patient's going to drive with a monster truck, you want to do digital instead of conventional. We'll walk through a few cases now to kind of show how that works. This is a patient that received an immediate overdenture. So the teeth were removed, alveoloplasty completed, and implants placed and loaded at that same day. And so it's just showing the extraction and the surgical guide to guide the alveoloplasty. And these are the locator housings placed the day of surgery. And you can see we use the duplicate denture as a surgical guide with a window open, lingual to the teeth. So I'm sure that we have enough clearance there. This is going to be nice and strong. And then we're going to snap on our housings. Normally, I'll just use that little blockout ring like I showed you in the previous photos. But in this case, because there were sutures, I did use a rubber dam to cover that. They make really nice pieces of thick Teflon, like horseshoe Teflon that you could use instead of a rubber dam. They also make like a tin foil that's meant for this purpose that you can use as well. But basically you want to cover the sutures so that you don't accidentally attach them to your acrylic, because you will pull out all the sutures. And later in the chat, you can ask me how I know, because there's no more walk of shame than having to go back to the surgeon and ask them to redo their entire suture line after you pick up your housing. So this is where I'm mixing cold cure acrylic. So this is a jet acrylic or a snap acrylic, just mixed and put into a monoject to attach a locator housing. So truly any sort of acrylic resin is going to bond here, whether it's the Chairside or the powder liquid jet. And you can pick them up again, any resin. With printed overdentures, there's not a ton of data yet on which material is going to bond better. Most of the companies that I've worked with, I've asked them, and they have validated both the polymethyl methacrylate, which is going to be the jet, as well as the composite resins. The printed denture bases usually have a component of acrylic in them, as well as a component of composite. And I like to use the Chairside acrylic resins, either the Voco or the Zest or the GC, because they also have both composites and acrylic. So I feel like we're going to get a double bond that way, or at least one of them will attach. And this is showing that same case with the locators picked up. So you can see on the left, these are the processing rings. Those come out with that removal tool and get replaced with a blue retention. Again, the blue retention is the lightest retention. This was an immediate load case, so I didn't want to put a lot of force on those implants. So we started with a blue. You may have noticed those implants are a little close together. And we did that intentionally because we planned in the future for this patient to get an all-on-X on the lower, or an all-on-4 design in this case. And because of where the patient's anatomy was, if we have placed those 2 center implants any further apart, it would preclude her in the future from getting those 2 implants for the all-on-4. And this is based on Mish's philosophy of upgrading over time. This is a really, really cool study talking about immediate loading. Every time I talk about that case, I get a lot of questions about immediate load. And what they have found is that immediate loading is incredibly predictable in the mandibular arch. There's only one author that found a higher failure rate, like a notably statistically significant higher failure rate for immediate load versus delayed load. With that in mind, there was only like 2 articles published comparing maxillary immediate load for implant overdentures. I have personally not loaded with a removable denture, a single attachment denture on the maxilla ever, just because I'm concerned about that failure rate. This was a case that I saw when I was in residency that actually had 6 implants when she started. And when I met her, she was down to 3. And you can see she has some more that are ailing throughout. So whenever we have the single attachments in the maxilla, it's just it's a more challenging case. The bone in the anterior mandible is the densest bone. We end up getting really amazing primary stability almost all the time, and that remains throughout the healing process. So throughout osseointegration, we have that really great stability of the implants in the lower anterior mandible. On the maxilla, we're usually D3, D4 quality bone, and that's a little bit more spongy, a little bit softer, and we don't necessarily get that same stability throughout osseointegration. I think resilience is a more technical term than spongy. And so if you've ever done that implant placement hands-on course where you place the implants in the different types of wood, it kind of shows you that when you place in that dense wood, that's similar to the anterior mandible, and then you place it in softer and softer wood as you go further back to the maxillary. The best article I have found about this is with a Dennis Tarnow article from 2007, talking about implant retained maxillary overdentures. And these ones, he had partial palatal coverage. And so they did do a metal framework on all their cases, and they did cover the hard palate with that metal framework. So you can imagine that a cast metal framework covering the hard palate is going to give that denture quite a lot of rigidity. And they had really great success with those. So there's a lot of debate on how you load the maxillary implants. Splinting them in some way is going to give them higher predictability. Whether that's splinted with a metal framework that's quite rigid, or whether it's splinted with a bar overdenture, that's up to the clinician and the patient and the technician. And this is just a quick table comparing the maxillary to mandibular implant overdentures. On the mandibular arch, I say a minimum of 2 implants. There have actually been a number of studies showing 1 dental implant placed in the midline actually does have a reasonably high success rate as well. So if you ever get into a pickle where your patient can't afford or doesn't have the bone for 2 implants, you can actually cheat and get away with 1 implant as close to the midline as possible for the mandibular overdenture. On the maxillary, it's pretty consistent through the literature that you want a minimum of 4 dental implants on the arch, sometimes more. The more the better, if they can be placed parallel or if they're supporting a bar. We know the bone quality is denser on the mandibular arch. And because of the framework that we're dealing with and trying to decide if we want palatal coverage or not and how we're going to attach that framework, usually the complexity is often higher on a maxillary single attachment overdenture. So looking at bar overdentures next, these are going to be where we're splinting rigidly the implants on the arch to support a framework, and then ultimately a denture. You can see this is a case that we didn't want to load the implants individually. These screw holes that you can see in the middle are where the dental implants are placed. And because they weren't placed very ideally for locators, I wanted to get a better rigidity with the bar. And then the locators can be placed anywhere. So the locator attachments on a bar don't have to line up with where the implants are. And they don't even have to line up with the number of implants. So you can have 3 implants and 5 locator attachments on a bar. It's just kind of based on the design of the bar, and the shape of the arch. This is going to show a mandibular bar overdenture. And you can see again, we have 4 implants on the mandibular arch where these abutment screws are. So the bar screws into the implant, and then the locators get tapped into place. And so here again, we have 4 locators. Typically, we won't do more than 4 locators on a bar because they're perfectly parallel And since that path of insertion is so good, it's literally milled by a milling machine. With that perfect parallelism, once you get more than 4, it's really hard to take the denture on and off. And I've had cases with 4 locators that I couldn't put all 4 attachments on because me and the patient couldn't take it out if we added that 4th one. So we left it at, there's 4 locators, but I'm only attaching 3. And then you can see what the piece that fits the overdenture looks like on the other side with a metal framework inside as well. So this is the bar. Sometimes we'll call this a substructure. And this is the piece that fits up against the tissue. Then we'll make kind of this mesostructure or superstructure that will be cast to fit over the bar and ends up getting processed inside the denture. So that's what gives the rigidity to the prosthesis itself. Because you can imagine having 4 locators on this bar, we've had to hollow that denture out quite a lot. So it's going to be at a higher risk of fracture. And this metal framework that gets processed inside helps prevent that from fracturing so much. And then you can see where the locator attachments get picked up inside the denture. Again, these are often picked up chairside because they're being processed on a bar. These are a little bit more predictable, however, to process in the dental laboratory. What's nice about this, about doing a bar versus a single attachment overdenture, is you can see here that the bar is actually what's touching the tissue. So this prosthesis is getting its support, stability, and retention from the implants versus the locator overdenture, we're only gaining retention from the implants. So this is what, when you say a fully implant supported overdenture, you're thinking of something like this, like a bar. This is nice because it gives cross arch stability to the implants, so they're gaining strength from one another. So you're going to have less loading on individual implants. And when you design it this way, you can actually pull it up off of the tissue. And so the flange does not have to touch the tissue if you do a bar overdenture that's fully implant supported. So to kind of summarize the different types of prostheses, when we're looking at a single attachment overdenture, we're only gaining retention from the implants versus a bar overdenture where we gain support, stability, and retention from the implants. For a single attachment overdenture, we need 8.5 millimeters of restorative space. Once we add the bar and the locators and the substructure, we need at least 14 millimeters. And this table kind of summarizes all of that. So because of the complexity, higher implants, the bar, the framework, we're looking at a much higher cost for a bar overdenture than a single attachment. The space goes from 8 millimeters to 14-ish. And obviously, as we have more implants, more pieces, it becomes more complex. 4 implants versus 2, we're looking at greater surgical needs. However, we're getting a prosthesis that's fully implant supported. This goes through the bar overdenture and the different measurements. We can cheat and go down to 10.5, but really that's going to put you at a higher risk for prosthetic complications, including teeth debonding, prosthesis fracture, and housings coming unglued. The lovely thing with digital, again, I know I love this stuff, but the communication between the technician and the dentist is unparalleled with digital dentistry. So when I send my technician my final impressions and my wax rim, they can virtually arrange the teeth and virtually design the bar and send me a digital preview where I can start to see where everything's going to be. And so here I can say, you know what, it looks like we don't have enough clearance in this area. Can we make the bar shorter or redesign? Can we move the locator underneath the canine instead of the lateral? And we can start to get really particular about how we want to see that prosthesis design. And again, this is something that was not possible with conventional dentistry. And I assure you, because I made a number of these with conventional and it was painful, digital has really, really made this process so much more predictable and so much easier to communicate with your dental technician. So I'll finish up with this gentleman. He came in with 3 teeth that were super periodontally involved. His molar back here was hanging in there. So we were going to plan an implant supported overdenture for him. He currently had a partial. Again, these 3 abutment teeth are failing, and he needs another solution. So we start at the very beginning, planning where we want the implants placed based on where we're going to have the teeth positioned. Will dictate where the bar is. So we can start with a crown down approach where design your digital denture. That will determine your bar design, which will determine your implant placement. And then ultimately we get this milled bar. These are milled out of titanium. Now you can mill them out of cobalt chrome. And I've started to see a lot of laboratories now printing these bars. So they're actually laser sintered out of titanium, which is really, really cool. The 3D printing of the metal is going to allow us to start getting a little bit faster. There's only a few labs that mill this titanium to this level of accuracy. And so having the printers will really expedite that process because we can print several bars at a time, but you can only mill a few at a time. And so this is showing the bar on the master cast and the bar try-in intraorally, and then our final prosthesis. And so you see we do have the hard palate covered with our major connector here. You will appreciate on this photo that we actually maintained that one lone molar in the back. The patient asked me, is there anything wrong with that molar? And I said, no, other than it's not in the ideal spot. And he asked if I could work around it. And I said, yes. So you see, we don't have a retentive arm on this. So it's not a tooth and implant supported partial. It's really an implant supported partial with a rest seat on this tooth to keep it from hyper erupting, and a bracing arm to kind of help guide the path of insertion. But there's no retention on that tooth. There's not a third arm on the buckle or second arm on the buckle. So I hope that helped introduce you to some different options that we have today with implant overdentures. So I hope you learned something nice. I'm excited to share my time with you.